In 1939, baseball great Lou Gehrig was diagnosed with amyotrophic lateral sclerosis, or ALS, the disease that would come to bear his name. Known as the Iron Horse of baseball for his accomplishments on the field, Gehrig soon found himself forced to retire as a result of this disease. The ALS Association's Greater Philadelphia chapter serves patients and their families living with Lou Gehrig's disease in portions of eastern Pennsylvania, New Jersey, and Delaware. Our mission is to lead the fight to cure and treat ALS through global cutting-edge research, and to empower people with Lou Gehrig's disease and their families to live fuller lives by providing them with compassionate care and support. This video will provide an overview of the disease for professionals caring for people with ALS and their families. At the end of this video, you should be able to define ALS and to have a basic understanding of the disease. You will be able to identify common signs and symptoms and have some knowledge of treatments. You will also gain awareness into the psychosocial impact on patients and the resources that the ALS Association provides. Amyotrophic lateral sclerosis is commonly known as ALS, or simply Lou Gehrig's disease. It is a devastating, progressive neuromuscular disorder that causes eventual paralysis of all voluntary muscles. Life expectancy averages 2 to 5 years from the time of diagnosis. Approximately 10% of all people diagnosed with ALS live longer than 10 years. ALS is a motor neuron disease. The motor neurons, or nerve cells, allow messages to travel between the brain and our voluntary muscles. In ALS, the motor neurons die for no known reason. Unable to receive messages, the voluntary muscles then atrophy. Eventually, people with ALS become paralyzed from the forehead to the toes and can no longer speak, swallow, or breathe on their own. ALS is an equal opportunity disease affecting both men and women of all races and ethnicities. Worldwide, there are 1 to 2 cases of ALS per 100,000 individuals. While most cases of ALS are diagnosed between the ages of 40 and 70, this disease can surface in individuals as early as in their 20s to as late as in their 90s. Approximately 95% of the cases are considered sporadic, meaning random occurrences. In cases of sporadic ALS, researchers do not yet know what causes the disease. Between 5 and 10% of cases are familial, meaning there is a genetic component. There is no single test to diagnose ALS. It must be diagnosed by ruling out all other possible causes of symptoms. For this reason, diagnosis can take months or in some cases even years. A positive diagnosis should come from a neurologist specializing in motor neuron diseases. It is confirmed by a positive EMG electromyogram and negative results from other tests, including blood work, MRI, and CAT scans. Patients should also exhibit a history of progression of symptoms. ALS presents itself differently in every patient, though common early symptoms can include a weakness in the arms, hands, legs, or feet that progress over time. In some cases, muscle weakness can start in the speaking, chewing, and swallowing muscles, otherwise known as the bulbar muscles. People who have ALS with an onset of symptoms in the bulbar muscles usually report a change in voice quality and tone, and/or difficulty with chewing and swallowing food. As it runs its course, ALS will eventually affect muscles in the arms and hands, legs and feet, chest, abdomen, back, neck, throat and mouth, tongue, face, and diaphragm. ALS, however, does not affect the senses or sexual functioning, or internal organs like the heart, liver, kidneys, or lungs. Research within the last few years suggests that greater than 50% of all people with ALS have some cognitive impairment, including impaired judgment and change in personality. In most cases, the impairment is mild. However, a small percentage of people with ALS will also develop frontal temporal dementia, or FTD. FTD is characterized by extreme impairment in judgment, loss of inhibition, compulsiveness, and poor insight. Symptoms of FTD can occur prior to symptoms of ALS. While causes and cure remain elusive, researchers are making significant progress. researchers have identified a problem protein inside the motor neuron. And in cases of familial ALS, 20% have a positive mutated gene known as the SOD1 gene. There is only one medication currently approved by the FDA for treatment of ALS. Riluzole, manufactured under the brand name Rilutech, is thought to extend life in patients by about 3 months. ALS care, therefore, is predominantly palliative, meaning that we strive to help patients manage their symptoms. Patients may experience a variety of symptoms related to ALS. In this section, we will outline some of the most common symptoms and discuss the best therapies for treating them. As the muscles weaken, patients may experience increasing fatigue from even simple day-to-day activities. In addition, ALS patients may experience insomnia or trouble sleeping at night, which also factors into fatigue during the day. ALS patients need rest, and more rest. Don't push them to do more than they are comfortable with. When planning daily activities, try to space them out and allow ample downtime. Helping patients with activities of daily living, such as brushing their teeth, eating, or pushing their wheelchair, will allow them to conserve their energy for other activities. Mobility also becomes problematic for people with ALS. Muscle contractures, cramps, and spasms are a common problem and can cause significant pain. Cramps, often described as sharp pain similar to a charley horse, and/or spasms described as a pulling or tight feeling in a muscle, can occur in any voluntary muscle. Contractures or frozen joints can occur if the patient is not able to do range of motion exercises on their own, or if a caregiver is not doing it for them. Help prevent muscle contractures with range of motion exercises as often as possible. Remember that the disease is progressive. The ALS patient will be able to do less and less of their care over time, and physical exercise will not help them to rebuild muscle strength. Symptoms of respiratory insufficiency will occur as the diaphragm and other muscles used for breathing become weak. Symptoms may include shortness of breath, morning headaches, difficulty sleeping, and daytime sleepiness. Non-invasive positive pressure ventilation, also called NIPPV or BiPAP, is the primary treatment for respiratory insufficiency in ALS patients. BiPAP is a non-invasive treatment which assists the respiratory muscles in breathing. The patient will wear a mask over their nose or face, which is connected to the BiPAP machine. BiPAP is usually used intermittently, often just at night. Some ALS patients may choose mechanical ventilation when BiPAP is no longer effective. Mechanical ventilation is considered invasive, as a patient will need to have a tracheostomy, which is then connected to the ventilator. The ventilator then does all the work of the respiratory muscles. An ALS patient using mechanical ventilation requires skilled care 24 hours a day, 7 days a week. Extra precaution should also be taken to shelter ALS patients from the contact with other patients, visitors, or staff members who have a cold or respiratory infection. As the disease begins to affect muscles in the throat, patients will experience speaking problems and difficulty swallowing food. There are several techniques, however, that patients may find helpful as they begin to experience swallowing difficulties. These include tucking their chin while eating, chewing food slowly, and not talking during mealtimes. Some patients find it easier to eat smaller, more frequent meals. Patients may find that they have particular difficulty with thin liquids and with foods with two different consistencies. Some ALS patients with significant chewing and swallowing problems elect to have a feeding tube placed to meet their nutritional needs. Additionally, patients may experience difficulty managing their secretions. Saliva and mucus can become thickened and at times require medical intervention. Finally, staff members who work with ALS patients should know the Heimlich maneuver in case of emergency. Speaking problems can be managed through a combination of communication techniques and assistive technology. Patients should speak slowly and say the most important word first. Caregivers can ask yes or no questions to minimize the amounts of speech needed for a response. Patients who still have use of their hands or arms can write their messages or use a communication board to express themselves. Devices that translate text into speech may also be available for loan through the Greater Philadelphia chapter. Be sure that patients with limited speech have a means to call for help. This can be as simple as placing their call bell where they are able to reach and use it. ALS takes a mental as well as a physical toll on those affected. You may find that each patient reacts differently to dealing with this devastating illness. People with ALS have many difficult decisions to make regarding their care, which will ultimately affect their prognosis and quality of life. There are no easy answers when deciding whether or not to use a ventilator or feeding tube, where to live as the disease progresses, and who will provide care. Our goal is to provide ALS patients and families with supportive treatment and services to maximize quality of life. ALS also makes a significant financial impact on a family. In its advanced stages, ALS care can cost as much as $250,000 a year. Let's review our key points so far. Remember that ALS is a progressive disease. What a person with ALS can do today, they may not be able to do tomorrow. Most ALS patients will remain mentally alert even if they have no way to communicate. Caregivers should allow patients to direct as much of their own care as possible. By now, you should have a better understanding of what to expect with ALS patients and how best to accommodate their needs. While the disease can be daunting, the Greater Philadelphia chapter is proud to offer a full range of support and services for people with ALS through the Leah R. Powell Patient Services Program. Our service area includes central and southern New Jersey, eastern Pennsylvania, and the full state of Delaware. The chapter supports and staffs 2 ALS Association-certified clinics for the diagnosis and treatment of ALS patients. The clinics provide multidisciplinary support. Patients may see up to a dozen specialists in a single visit, as the clinic staff includes a neurologist, a nurse, a social worker, physical and occupational therapists, a respiratory therapist, a speech-language pathologist, a mental health counselor, an assistive technology specialist, and a dietitian. The clinics are located at Pennsylvania Hospital in Center City, Philadelphia, and the Penn State Hershey Medical Center in Hershey, Pennsylvania. We have also established specialized ALS clinical care at Geisinger Medical Center in North Central Pennsylvania and at Lehigh Valley Hospital in Allentown, Pennsylvania. We provide educational programs to help families dealing with ALS, from newly diagnosed seminars to managing ALS teleconferences, to research updates, to our quarterly newsletters for families and patients. To help families manage the cost of this disease, we provide all of our services to patients and families at no charge. These include transportation to doctor and clinic visits and to chapter events in our wheelchair-accessible vans, the Marjorie Scheimer Durable Medical Equipment Loan Program, which lends equipment such as wheelchairs, tub benches, commodes, and lift chairs to patients for as long as they need them. The Cox Family Fund for Accessibility, which assists families with home modifications to accommodate wheelchairs. We will help families build ramps, rent stair glides, and set up emergency call devices. Evaluation of patients for communication devices, and a loan program for adapted equipment through the Dr. Scott A. Mackler Assistive Technology Program. We have programs designed for families who maintain care of the ALS patient in their home. Our Howard I. Abrams in-home care program provides supplemental hours of in-home care aides for patients on a continual basis. We provide respite care in instances where a family caregiver needs time out of the house. In addition, nurses, social workers, the assistive technology specialist, and the mental health nurse will make home visits as necessary. We clearly recognize the importance of companionship and a support network for families dealing with ALS. We hold monthly resource groups at multiple locations throughout our service area to bring families together to share experiences and ideas. We offer a visiting volunteer program as well. Our Patient Services Department offers recreational activities throughout the year at no charge to patients and their families, including trips to amusement parks, botanical gardens, the zoo, and more. And each fall, we provide a unique program for family caregivers called Nurturing the Nurturer, a special day for caregivers to meet others in their situation and enjoy being pampered. Over the last decade, the ALS Association has committed nearly $40 million to ALS research. The national organization currently funds more than 100 diverse research studies worldwide. Our chapter alone contributes in excess of $800,000 in basic science research annually. Each year, hundreds of ALS patients, family members, and friends converge on Washington, D.C. to bring the ALS message to our legislators and to request increased funding and support. Please remember, the ALS Association Greater Philadelphia chapter is available to provide assistance for ALS patients, their family members, and caregivers. Services are provided at no cost to any patient living in our service area with a diagnosis of ALS. We hope that this video has provided you with valuable information that you will find useful in your care of ALS patients.
You have to have patience. If you don't have patience, don't take the job.
For more information, contact the ALS Association toll-free at 1-877-GEHRIG-1 or on the web at www.alsphiladelphia.org.